All right. Thank you, everyone. I'm Sherilyn Pruitt, and I'm going to introduce our next panel. It's the Healthcare Continuum, and we have 3 speakers today. I'm very happy to introduce you to them. The first speaker is Bill Appelgate. He's the Executive Director of the Iowa Chronic Care Consortium, and he's going to talk about promoting health, preventing disease, and prompting population progress. Our second speaker is Joseph Tracy, the Vice President of Telehealth Services at Lehigh Valley Health Network. And our third speaker is Sanjeev Arora, the Director of Project ECHO, and he's going to speak about chronic disease management. And I think you all heard a little bit earlier, Project ECHO is one of the award winners for the CMMI Innovation Project. So with that, who's going to start first? Is it Bill or Sanjeev? Okay, Bill's going to start first. Come on up. Thank you.
Good afternoon. You see that title? Isn't that a daunting title? I really asked for world peace, but they just gave me this one. I guess it was a negotiation. I think I just clicked this. Is that right? Okay, so my name is Bill Appelgate. I work with the Iowa Chronic Care Consortium, and I'm going to say some things about health systems and things like that over a period of time. And I do want you to know that I've worked in them, was the CEO of multiple healthcare systems for a number of years. So I'm not really on the outside, or at least maybe I'm on the outside now, but I do have some experience in those systems. So I say some of the things that I say with a little bit of a view of what's going on there. And then for about the last 10 years, I worked at a health sciences university and medical school while founding the Consortium, which is Iowa, because it says Iowa Chronic Care Consortium, but we do work in about 28 states. And so we have a number of projects going on around the place, around this country. I wanted to show you this slide, one, because it's my favorite slide in all the world. I have it framed in my office in color, and this is what we all do. We all play in this in different areas, and the better we can play in it, the better off our health of our nation will be. And I love to talk about individual parts of it, and we have little quizzes sometimes among our staff saying, pick out one block of this, and then tell me about something really important that you want to share about that block, because we really enjoy this a great deal. I want to make some personal disclosures, mostly because a lot of people making personal disclosures. I have no money, and it hasn't been doing very well, so I don't even know where it is, so I couldn't really tell you if I have it in the right place or the wrong place, so I do want to say that. But I thought there are some other personal disclosures that would be good for me to share with you. Number one, I am deeply, deeply devoted to making health happen by deploying shockingly simple strategies that touch and improve the lives of people. And I want you to know that those are really making better health and lower cost, and which is better health care. So we're kind of involved in the triple aim, but we really focus a lot on achieving better health and lower cost. I have a profound reverence for salutogenics, and I don't know if many of you know about salutogenics, but it's like the opposite of pathogenics in a way, and it focuses on the building and establishment of health. Actually, that's my favorite subject to talk about. I won't do that today. But it really is an interesting kind of thing when you look at the world, particularly look at the world by the slide that I just showed you, and think of it as our moving health in a positive place. And then I have a curious irreverence for the kind of over-pathogenic, related to pseudogenic above, healthcare industry, which we're all involved in and know of in different ways, which seems to busy itself with a lot of very costly approaches for fixing the broke, healing the sick, and diagnosing chronic conditions, but then seems to do very little about actually mitigating the progression of this most costly component, by the way, of healthcare expenditures. And the last thing I want to disclosure is to say that, and you'll learn a little bit about this, the Iowa Chronic Care Consortium is a nonprofit organization, and we've developed and we actually provide clinical healthcare coaching. I'm going to talk about that in a little bit. Okay. Here's what I'm going to do today. I'm going to talk about some truth about managing chronic conditions, because I believe that the real lever for moving healthcare in this country has to do with chronic conditions. So I really like a lot of things that are going on, but a lot of them are on the periphery of where the money is. So the Willie Sutton comment, which somebody made a comment about earlier today, why do you rob banks? Because that's where the money is. I just want you to know the money's in chronic conditions, and the extent we can do more there, the better off we're going to be. And a lot of healthcare can be better off. I want to share some field-proven experiences. Just about everything we do is telehome care and telehealth-based, because we don't believe that you have to come to the office, whatever that is, or the hospital, to do an awful lot of things to get really powerful results. And then I want to explore clinical health coaching and how I believe it's really the lightning in the bottle for achieving real change in our health populations. I did a presentation a couple weeks ago at a meeting, and I asked everybody, and I'll just ask you, how many of you in the audience are now directly or indirectly interested in management of chronic diseases? Okay, good number. Now the question is, if you're involved in directly doing that, where are you when you take a look at these different options? That is, do you identify those with chronic conditions and act proactively? Do you identify and manage those chronic conditions fairly well? Or do you wait, in effect, until people present themselves exacerbated, whatever that means, with their chronic conditions, and then you deal with that at that point? So these are the kinds of questions that are really important, and so you have to reflect on that for your own organizations, and I hope that what I'm going to share with you in the next few minutes will help move you to a better place on this screen than maybe where you are at the present time. And why are we in those conditions? Well, sometimes we're unclear about what our desired results are. By the way, big organizations are still having a terribly difficult time understanding, where it is we really want to go with chronic conditions and how we're going to do it. If that's not a problem enough, reimbursement, we heard about it in the last session, reimbursement is really inhibiting getting us going where we want to go. And there's the promise of something better, but we don't have it yet. And then, frankly, there's not a lot of confidence in what we need to do. And so I review a lot of proposals like a lot of you do, and I review them for organizations that we know of. And I'm always interested in how we have big setups for lots and stuff happening on the front end, lots of data stuff being developed now. It's really impressive, okay? And then we have outcomes over here, but I'm lost in space in this magic in between about something that's going to actually happen in the lives of people that gets those outcomes. In fact, I just don't see them very often. So, what's the promise of healthcare reform? Well, we're going to expand access. We're working on that. Prompt healthcare insurance reform. We've done some of that. We're implementing new strategies of payment reform through CMMI and others. Hopefully, we'll achieve some overall healthcare system reform, and then we're going to reduce overall cost of healthcare. I think we're doing some specific things in number 1 and number 2, and some in number 3, but certainly the last couple of them are kind of what I call faith-based. Strategies and promises of healthcare reform. And by the way, I really believe in it a lot, but I think we need to work towards those. So I want to talk about the big thing. And some of you say, well, this is not a secret. Well, if it wasn't a secret, then more people would be doing it. Okay, so here we go. This is undeveloped and often unspoken. It saves costs for individuals, saves costs for health plans, saves costs for hospitals, governments. It saves costs all over the place. Oh, and by the way, it improves health care and does a lot of other things, and we can do it. It's within our ability to do it. And what it is keeping individuals selected chronic diseases out of the hospital and out of the ER. That's just it. Now, some of you say, well, I know that's big, but what does all that mean? Well, I want to fact check it a little bit, and I want to draw a little picture for you. 50% of the people on Medicare right now cost $550 a year or less. This is a lot of people. So what does that mean? That means that a bunch of them are costing a lot more. And we go back to some data that isn't too new, but that's how a lot of Medicare data is. In 2007, the average Medicare beneficiary with heart failure cost about $25,000. COPD about $20,000, diabetes about $13,000. Now, if you flip back and say that 50% are costing $550 less, this is where our money's going, and you know it. The percentage of costs associated with hospitalizations and ER visits in the Medicare population, and mostly around chronic disease, is 83%. So this is where the money is. And what we also know is that we can do interventions that are going to reduce that substantially. So what do we got? We've got a sick care system, which a lot of us have talked about, been mentioned today, that really needs to be more of a well care system. So, hey, we need to move from pathogenesis to salutogenesis. And all of you know that. This isn't like rocket science, okay? But we just have a very difficult time doing it, largely because of the systems and the structures that we have. Chronic disease counts for a lot of our expending, as a couple of these comments report. And then what's also true is that chronically ill patients only receive about 56% of recommended health care. Well, this is kind of grim. I think the comment is that it takes 17 years to take an innovation or facts we know of and get them implemented in healthcare. Actually, we've known about the standards for diabetes for about 23 years now, and we're still not getting 50% of those being applied with individuals with diabetes. So really, our performance sucks. We aren't doing very well, and so we've got to get to places where it does better. And the last thing that I want to mention, because this is a big setup, and that is the patient is really the greatest untapped resource in healthcare. If we can get to that, then we're going to have a little better opportunity. So, what's responsible for this gap that we have? One, well, we're pretty oriented to chronic disease, or to acute disease, because that's where a lot of the money is, particularly for hospitals, okay? The misappropriation of education as an end game is a real problem. So here's how it goes. Healthcare professionals, if you tell me, you're the healthcare professionals, I'm the patient, I'm the individual. You tell me what to do, and we have operated for a long time under the assumption that after you've told me, you've done your job. Well, that isn't true. Okay, because it hasn't changed my behavior, it hasn't necessarily changed my performance. And lastly, we have an artificial over-reliance on coming to the healthcare provider to get chronic disease managed. Oh, I'm so sad, it's too bad. It's too bad. Okay, here we go. I want to talk to you about some projects. Now, these aren't about what we've done. They're really about what you can do. These are telehealth projects. In full disclosure, I need to say that the Office of Management of Telehealth has funded some of these because they had faith in us, I guess. And I just want you to know, I hope we haven't let them down, because we found some really interesting things. So, by the way, we like to work with Medicaid populations. By the way, we work with other populations. We're working with the Nova Health System. Their Heart and Vascular Institute asked us to design their heart failure program for their 265 cardiologists. We did that. We're doing things all over. But we like to cut our teeth on things like Medicaid, because if you can do stuff in Medicaid, you can do stuff any place. And so why not start where it's hardest, and then it becomes easier other places. So 266 Medicaid members with heart failure. They cost $24,000 when we did this. We have daily contact and care management, all by phone, all ubiquitous, no home monitoring devices. It's very heavily technology leveraged, and we avoided hospitalizations and a lot of ER visits. And for an expenditure, just so you get this, the entire get dressed up for a party expenditure of about $330,000, we saved over $3 million. And by the way, this is no science project, bad evaluation. We did matched control groups. These are pretty powerful designs to show this. And so this gives you some idea. Here are the expenditures in our match cohort. Here are the expenditures in our project. We have another one I'll just show you. This is underway at the present time. This is a 2010-2012 project on diabetes. The match control group, just so you know, our inpatient visits are 54% under for those the control group as opposed to the match cohort. Outpatient, 13. Office visits, down 6. Actually, that's not bad. A lot of our projects, we have office visits go up. What's the relationship between a hospitalization and an office visit? 1 to 100. So an office visit, generally speaking, whether it be for heart failure or diabetes, costs 1% of what a hospitalization costs. So I don't care if we double, quadruple, triple our office visits, we are well on the way if we can prevent a hospitalization. So the total cost reduction in this is about 20%. And by the way, the return on investment, pretty shocking in this. So, and I just got off the phone with CDC. We're just getting the results right now of a project we're doing. We want to do behavior change in health and wellness, and here we are, Medicare people, 58 to 63. And we took farmers because they're an easy group to change behaviors in. And we gave them health risk assessments, and then we gave them education, and then we gave them diet and exercise and prevention incentives, I must confess, and then we gave them coaching. And here did we get? We got reduced risk, improved health status, and we've got a lot of zero trending. So here's how the world works. As we grow older, by the way, we believe in population stuff, so I don't want to talk about individuals, but because you're all better than this, but as populations, our health risks go up when we grow older, and our health status goes down, right? Okay. So what our job is to hit that group and go in there and say, how can we zero trend those? Okay, so Dee Eddington has a lot of thoughts about this. That's just what we've done, and we're going to report that out in a couple of months, and I'm going to be very, very happy to talk about what we've done. And it's exclusively done exclusively done telephonically. Even the HRAs and the fasting blood sugars and everything are all done by home kits. So nobody has to go to any doctor to do this, although doctors are involved in this if they want to be. So something else we've done, something called proportionate benefit analysis. We don't really pay enough attention to something that's really important. And what it is if I don't go to the hospital or you don't go to the hospital, who saves money? Well, it isn't just me or you, and it isn't just our health plan. All kinds of people save money. In fact, 50% of the hospitals in this country, happy to name some names, are losing money on Medicare heart failure admissions. They don't know it, but they are. Some of them believe that it helps build their baseline costs, so it's okay. Now, here we go. Maybe. Our telehome care learnings. 89% of the health care in America takes place actually in the bedroom, bathroom, and kitchens of our own homes. So if we can't get to those places with people, we aren't going to get healthcare changed dramatically. Engaging individuals in self-management of their health is priority one. That's something we do in all of our projects. And we can get a preponderance of these kinds of interventions that can take place telephonically. Now, I want to tell you something. This is kind of the CCDN. This isn't a secret, but how do we get the results we get? Well, here's one of the ways we do it. We create groups of people, physicians, hospitals, docs, who knows, different groups, and we spend about $100 a month, PMPM, for a lot of people with chronic disease. We give $35 a month, or $35 PMPM for care coordination, $12 for physician coordination, $50 for technology and registries, and about $5 for the network. You get pattern groups of people doing this, and you can do just all kinds of things. So if you believe in medical homes or you believe in ACOs, I want you to know that we're working with a lot of people on both of those. This is really well fit for that, and it's scalable to all payer applications. So I want to talk about health coaching. We were getting a lot of results, and we came to the conclusion that one of the reasons we're getting results is we're getting to that 80 to 90% of the health care that takes place in the bedroom, bathroom, kitchens of our own homes. So then we decided we better get there even better, smarter, quicker. And so we developed health coaching. And so all of our projects have pretty active health coaching in it. Health coaching isn't like a football coach, okay? Health coaching isn't like a teacher telling people what to do. Health coaching is its own style. And it's really kind of important. But why do we want to get to behaviors? Because if you take a look at factors contributing to health and factors contributing to behavior things, what you'll see is a lot of them are, in fact, well, how do you want to say it? Malleable. And if you can get to those, you can make big differences. There's two simple truths that I want to share. Most care is self-care. AHRQ just came out with a statement, I think a study this 2-3 weeks ago, saying that 95% of the diabetes care in America takes place with self-care. That's important. And the patient is the biggest untapped resource in healthcare. So what we're doing isn't really working. We aren't getting to people like we want to. So what we have done is created something called the evidence-based health coach. And what that involves is two elements: transform the conversation. That's what takes place between the provider and the individual. We don't call them patients very often. We call them individuals. And the truth of the matter is that's where we're trying to get. Am I about done? Okay. So let me just go through and get to a couple of things here. One other thing that we do is we measure all around the clinical value compass. I want to make some recommendations here. I call these the loving suggestions for HRSA. We need to support telehealth projects and demonstrations with robust evaluations, and that means research quality. Somebody said today, well, we can't really get to clinical trials. I get that fully. I know that we can't get to clinical trials. The truth is, if you can use matched control groups and other powerful designs, you can do it. But the reason we need to have pretty good designs is that there's a lot of bad evaluations, and you might as well have some good ones to prove the efficacy of what works. You should always measure around all points of that clinical value compass. I think we need to take a look at projects that leverage work on costly chronic conditions. We aren't doing that quite enough. Another thing that we need to do is that we need to, provide some design and evaluation technical assistance to projects. Need to work closely with CMS, and we've seen some good demonstrations of that. And I think lastly, we need to take a look and test the value of some kind of clinical health coaching, because remembering the idea that so much of the care that takes place in this country happens as a function of self-management or self-care. If we don't get to that, we have to have better strategies, and that won't revolve around changing the healthcare system as we know it now. Thank you.
Good afternoon, everybody. Thank you. I'm Joe Tracy, Vice President for Telehealth Services at Lehigh Valley Health Network. I'm going to go as fast as I can because I don't want to see the red light. I think you get electrocuted.
Hey, by the way, it's hard to beat.
Okay. All right. Well, I'll give it a shot. I'm going to take about 15 minutes and tell you about a couple of the programs we're doing in an acute inpatient setting, and then provide a few considerations for everybody to think about. Thank you to the Planning Committee, especially Karen and Tom, for inviting me to come and speak. So where's Allentown, Pennsylvania? Just hum the Billy Joel song, about 90 miles west of New York City and about 60 miles northwest of Philadelphia. Just to give you an idea of who we are, we're a big place, about 981 beds, 3 facilities. We employ about 1,200 plus docs, 2,300 plus nurses, and we have about 11,000 employees. So I'm going to jump in and talk about critical care right now and talk about some of the challenges that we have. So I'm not going to paint exactly a nice picture at the moment. You know, we've got an aging population. Somewhere between 8,000 and 10,000 people are turning 65 each day. And I know I'm getting younger, but we got to keep an eye on the rest of you. There's an increased demand for the service. There's an increased demand for providers. And, of course, there's always the lovely increased costs. It's about 90,000 ICU beds in the country, represent about 15% of all hospital beds. And actually, there is a decline in the number of hospitals with ICU beds. However, there's been an increase in the number of beds total. So we have fewer hospitals with those beds, but we have more beds overall. Approximately 540,000 people die in ICUs each year. Total cost is $107 billion annually. To run this type of care, and mortality rates average 10 to 20% in most hospitals. Only 10 to 20% of hospitals have critical care staffing that is dedicated, and only 1% have it at night. And the bad news is there's going to be a 35% shortage of intensivists going forward. So didn't exactly paint a pretty picture for critical care moving forward. So we need to find a way to be able to spread this expertise out beyond the large centers that are fortunate enough to have large ICUs and a large number of intensivists. So we developed the Tele-ICU at Lehigh Valley Health Network, started on it 10 years ago, and we call it the Advanced ICU. We did it because we wanted to, of course, improve patient safety. We also purchased the hospital and wondered, okay, how are we going to keep the level of ICU care at that hospital equal to the hospital, the larger facility? And we were already Leapfrog compliant, but we wanted to kind of go beyond what Leapfrog requires in terms of their intensivist staffing model. And frankly, it was the right thing to do. So let me introduce you to Matt McCambridge. He's one of our intensivists. Actually, he's chief of critical care at Lehigh Valley Health Network. He's sitting in front of one of 4 identical pods. And I'm going to describe these to you in detail. And just so you know, in those pods, Matt has every information tool that he would have at the bedside. And he has it in a remote location. Let me describe it to you. Because I don't think it's all about an audio-video system. I think it's about a combination of all sorts of health information technology, which we're kind of referring to as our HIT bundle. So in the AICU, Matt has access to the PACS system. He's got real-time audio and video into each room. He can actually zoom the cameras in and do a pupillary reaction. He can see that from the remote site. We've got an electronic medication administrative record. We've got physician order entry. All orders are done through that system. We have an ICU electronic medical record that also ties to the master medical record. We have an event system, so if a patient's vital signs head in a very bad direction, we know it within 1 minute. We also rely on our cardiology information system, and we have access to labs. So they have all these tools all night long. So what did it take to develop it? A lot of money. It wasn't cheap. It took 2 years to develop just on paper. We had to involve all the key stakeholders in doing it. We did site visits, and we also did budgeting and business planning. So let me tell you a little bit about critical care in the daytime. The physicians, mid-level providers, nurse practitioners are all rounding during the day, 7A to 7P, in 6 critical care units at 2 different campuses. Just so you know, the Lehigh Valley Health Network ICUs are closed, so the intensivists intervene and consult on every case in the ICUs. And just so you know, too, our trauma ICU and our burn ICU have physicians in-house all night long, so we don't cover those through the advanced ICU. So at nighttime, starting at 7 p.m., they're handing off patients that the physicians saw in the daytime to the Tele-ICU team. We're 1 board-certified intensivist, 3 critical care nurses, and 1 clerical team member are housed, and it's in a remote location separate from all 3 of our facilities. And just so you know, this is an added layer of care. This was an expense on the hospital system because we replaced nobody at the bedside. So this is just an added layer of care, a second set of eyes and ears to watch over these patients all night long. We have 12 board-certified intensivists that rotate through, 17 critical care nurses rotate, and 4 clerical team members rotate with a take-home point: nobody works full-time in the advanced ICU. They all maintain their floor duties, their unit duties, so that they can keep up their skills with patients on the floor. We also have access to anesthesia and the trauma surgeons at night, so if a central line is needed or an airway needs to be placed, we can call them in. So I'm telling you this to just put that a little bit in context, and then I'm going to talk here a little bit about outcomes. One of the first studies was out of Centara, I believe in Northern Virginia. They saw some dramatic results by implementing the Tele-ICU. Big decreases in mortality, length of stay decrease, which decreased their costs, allowed them to have more admissions through the ICU, and it contributed to their bottom line. And I will tell you, ours probably does too as a result of some of the length of stay. We're able to have more throughput into the system. We also published a study in April of 2010 in the Archives of Internal Medicine. And basically, we went back and we looked at 954 patients prior to implementing the ICU. We looked at 959 after. And we found a 31% relative mortality risk reduction in the study group, which was those now receiving care through the AICU. And in addition to that, we saw a significant reduction in the use of mechanical ventilation. We did have a drop in length of stay of 0.29 days, and while that was not significant from a statistical standpoint, it's always significant from the administrative standpoint and the ability to move more people through the units. And the key for me is to think about the patients that benefit from this. Based on that reduction in mortality, we're estimating that over 500 patients now, 500 more patients are leaving our ICUs alive in every given year, or any given year at this point. But while we had a positive study, there are also some studies that basically did not find the same results. This one was by Eric Thomas, and it concluded remote monitoring of ICU patients was not associated with an overall improvement in mortality or length of stay. Another study by Jeanette Morrison, and their study of over 4,000 patients representing 2 community hospitals, they did not find any reduction in mortality, length of stay, or hospital costs attributable to the introduction of the Tele-ICU. So why did our results differ from theirs? Well, in the Morrison study, they were looking at a model where only 73% of admitting physicians chose only low-level Tele-ICU involvement and only emergent interventions for life-threatening conditions or minor non-emergent management. So they were not using this to its fullest capability. The Thomas study, only 66% of admitting physicians chose minimal delegation to the ICU. In the Lehigh Valley Health Network with the closed ICUs, every patient is treated the same way every time. There is no difference in the level of care that they receive during the night. And so I don't think it really has much to do with the study, the methodology, the design. It has to do with the model of the telehealth program. I'll be the first one to tell you, if you want me to develop a really bad telehealth program, I can do that pretty fast. It takes time to develop a good one. So if you study a bad model, your results are going to be indicative of that model. And I would be remiss if I didn't do a shout out for my nurses who might be watching in TV land. Nurses, we looked at this early on, the effect of this health information technology bundle. Every nurse on each 12-hour shift got 95 minutes more of direct patient care time than they had prior to the implementation of the AICU. And they get that because all the devices in our ICUs are feeding the electronic medical directly. So they've reduced the amount of charting. They're still validating all the information, but they've got a lot more bedside care time back. And I'm just going to back up one slide. I guess I will just throw this out there for you to consider. If you put a network in place and you're not treating each patient the same in an ICU environment, have you created two levels of care? I'll let you think about that. I'm not the one to say whether that's true or false, but in some cases, if you're just not treating the patients the same, maybe you have. So back to the nursing thing, not only have they got more time back in direct patient care, another interesting thing that we hear time and time again is we don't have to wake up a sleepy intensivist at night and report on something that they may or may not need to talk to the intensivist about. So that's been a real positive for us as well. Now another project that we're working on in an inpatient environment is tele-infectious disease. And there's also provider shortages here. Some of these small rural hospitals have no infectious disease specialists, or they have one, and then you got to deal with the burnout issue. And so it becomes, how do we use this resource the best way? Well, what we did is develop a program to do inpatient consultations with remote physicians during daytime hours, standard set of technology, interactive video, stethoscopes, exam cameras, document cameras, and the docs have access to labs. We're in 3 hospitals. One's a rehab facility. We have 1 hospital awaiting installation, 2 hospitals seeking an agreement. We do not assume care of the patient. That stays with the hospitalist group at the remote hospital. We just simply do a true consultation, and we provide documentation back. Again, these hospitals have daytime hospitalists, and they actually pay us for the service. And you're probably going, okay, why would they pay you for the service? Well, this is one reason. This has gone beyond my wildest dreams. 85% of the patients we're consulting on now are staying in their remote hospital. This has big implications for the payers because these small rural hospitals are a much lower cost environment. You're reducing all the transport costs associated with an inpatient transfer, an interfacility transfer, and we kind of have to charge them because there's these little things called the anti-kickback statutes where you just can't give things away. And so we're balancing this on the back of these hospitals, and that's one thing I would like to see stopped. So let's see, is there anything else I wanted to say on that? We're also using all the services at the smaller hospital, their labs, their x-ray, and we're leaving beds open in the bigger tertiary care center for people who really need them. So I got 2 minutes before the red light comes on. And this is the part where if you go second, somebody's already said what you wanted to say, okay? So my goal, keep patients close to home in a safe and lower cost environment. And the two themes that we've heard here today have been reimbursement and licensure. Karen said it, Dale Alverson said it. On the licensure perspective, your address should not dictate where you receive care in this day and age. If I lived in New Jersey, I could cross the Delaware River on the Ben Franklin Bridge, go into Philadelphia and receive my care, no questions asked. Just don't do that electronically. To me, just like Dale and like Karen, that makes absolutely no sense. And we need to take care of that. One thing I want to really get to in my last few minutes is, one, do we need standards for Tele-ICU? This is also good for the rural hospitals. You're going to increase their case mix index and keep them thriving. But I don't know how many of you know that the Office of the Inspector General issued an opinion from a requester last September. And the requester asked, I have a telestroke program, and this telestroke program is intended to keep patients in their remote hospital. And I would like to give them the equipment. I don't want to charge them for the service. I will give them the protocols, and I will do the education. And for all of that, I would like to do this in an exclusive format where that hospital can only use my services for telestroke for 2 years. So they made that argument to the OIG. And the OIG came back and said, under normal circumstances, this would be a clear violation of the anti-kickback statutes. And it would. But they said, based on your argument that you hope and you will keep telestroke patients in the local communities, we will probably not prosecute this. You can make that argument for every single telehealth service you do to a rural area or any underserved area. So I would like us to think about, if they've gone that far, to basically kind of push aside the anti-kickback statutes, that we should try and go for a wider coverage of that, so that they waive those anti-kickback statutes for many more telehealth programs. And I think that's just something we need to do. And so there's my contact information. That's my story. I'm sticking to it. And thank you for listening.
I want to thank the Institute of Medicine for this opportunity. ECHO stands for Extension for Community Healthcare Outcomes. And the mission of Project ECHO is to expand the capacity to provide best practice care for common and complex diseases in underserved areas and to monitor outcomes. It's funded by the state legislature, Department of Health, the Medicaid Department, AHRQ, and Robert Wood Johnson Foundation, and most recently by Center of Medicaid and Medicare Innovation. The story of ECHO starts with hepatitis C. It's a global health problem. 170 million people have the disease, 4 million are in the United States, and it is expected that out of this 170 million people, about 20 million will die from this disease if the current rates of treatment continue. Most deaths occur due to either end-stage liver disease or liver cancer. In New Mexico, where we live, 28,000 patients had this disease, and less than 5% had even been evaluated for it. Just 3 or 4% had been treated, and 2,300 prisoners who had been diagnosed, none had been treated. We have the highest rate of chronic liver disease cirrhosis deaths in the nation in New Mexico at twice the national average. Why this was occurring despite the fact that this is a curable disease. There are 3 main genotypes. Genotype 1 could be cured 45% of the time, non-1, 2, and 3 about 75% of the time. Despite the fact it was curable, the bad news was the treatment involves weekly injections, pills, chemotherapy-like regimen, which causes anemia in 100%, neutropenia in a third, depression in a quarter. So not a single primary care doctor in New Mexico in 2003 was treating hepatitis C. Patients were trying to make it to my clinic. There was an 8-month wait to see me, and people would have to drive hundreds of miles, sometimes 200 miles each way, making 12 to 18 trips while they were on this chemotherapy regimen. And you can imagine why the access was poor. And New Mexico is rural. 32 of 33 counties are medically underserved, 14 are health professional shortage areas, and a quarter of the patients lack health insurance. Only 20% of our doctors practice in rural or frontier areas. So we developed a new model to take care of this problem with the goal of expanding the capacity to safely and effectively treat hepatitis C in all areas of New Mexico and to monitor outcomes. And we wanted to develop a model to treat complex diseases in rural locations, developing countries. So we knew if Hep C would work, we could do a lot of other things. At this point, you all know Dale Alverson. He was the head of telemedicine. I'm just a clinician in the Department of Medicine there, and I went to see him, and I said, look, I don't have any money, I have no grants, but I want to do this. And you know who your friends are because they are your friend when you're poor. So he actually gave me his facilities to use without any cost to me and help us set up the ECHO model in his facilities. And Dale, thank you very much for that. The first step was we developed partnership between the University of New Mexico, Dale, Department of Corrections, Health Department, Indian Health Service, and community clinicians who had an interest in hepatitis C. These are the 4 main pillars on which Project ECHO stands. If you have to remember one slide, this is the one to remember. First, we use technology, multi-point video conferencing and the internet to leverage scarce resources such as a hepatologist and psychiatrist at the university. Second, we use a disease management model focused on improving outcomes by reducing variation and sharing best practices. Third, we set up 21 centers of excellence for treating hepatitis C all over New Mexico, which were led by primary care clinicians, and we asked ourselves, how are we going to make them experts? And we said we'll make them experts the same way as we became experts, by case-based learning and co-managing patients with our professors, and by learning by doing. And lastly, we used the internet to track outcomes. This was published in Academic Medicine in 2007. We trained physicians, nurses in hepatitis C, trained them to use our web-based software to track patients and conduct telemedicine clinics, which we call knowledge networks. And this is what a knowledge network looks like. All these primary care clinicians from all over New Mexico join us simultaneously on an interactive video network. In the big box is University of New Mexico. I have a psychiatrist, a pharmacist, and then one by one these primary care clinicians present patients with hepatitis C. I have a standardized format. I need about 20 pieces of information. They give me all 20 in a maximum of 3 to 4 minutes. It's standardized. Our team gives them advice. We co-manage the patients and we go to the next place. Over 2 hours, typically we co-manage 15 patients with hepatitis C. We also give them a didactic presentation which lasts 10 to 15 minutes or so on some aspect of hepatitis C that we want to train them on. This, what you just saw, was a knowledge network. No patient ever comes onto this network. And the way these doctors learn and become experts is called a learning loop. They learn from us through our advice, they learn through our didactic presentations, they learn from each other, and mostly they learn by doing. We collect data and monitor effectiveness. We give no-cost CME credits and nurses credits, and we want to reduce professional isolation by improving professional interaction for rural doctors. We want to bring a mix of work and learning in their environment, because we've asked some of our rural doctors, why is there such high turnover? Of course, they tell us, look, there's no Bloomingdale's here and there's no Albuquerque Academy here. But the real issue is we can't tackle any of those problems. So we said, one of the things they told us is when they went to medical school and residency, it was a good mix of work and learning, but when in a rural area, we get frustrated because it's all work. So we said that's one problem we can tackle by bringing a mix of work and learning into their environment, by giving them access to multiple specialists and learning. We use very simple technologies, which I won't go over. We use a video conferencing bridge, recording devices so the lectures can be seen asynchronously in the night, webcam interfacing so that primary care doctors don't need a $3,000 camera. They can just use a webcam. We've done 500 such telehealth clinics for hepatitis C, more than 5,000 case presentations. We've expanded to multiple diseases and overall provided 27,000 hours of CME credit to rural clinicians in New Mexico for 19 different conditions. We know that a doctor is not going to be willing to treat a very complex disease like hepatitis C unless they have self-efficacy. And the reason is because there are lawyers out there. And so we studied self-efficacy. We asked our doctors before we started, what is your ability to identify suitable candidates for hepatitis C? Scale is 1, I have no skill, and 7, I'm an expert who can teach others. In 12 months, it goes from 2.8 out of 7 to 5.6. Question 3, what is your ability to treat hepatitis C and manage side effects? 2 to 5.2. Can you now serve as a local consultant within my clinic and in your area for hepatitis C questions and issues? Question number 5 goes from 2.4 to 5.6. Can you manage psychiatric comorbidities? 2.6 to 5.1. Overall competence goes from 2.8 to 5.5. This was published in Hepatology in 2010. We asked them, primary care clinicians are not just free all the time waiting for television shows to start. They have very limited time. They're not going to come on a network unless they find it beneficial. We asked them, is this kind of network beneficial to you? 97% felt it was moderate to major benefit. 94% being well informed about symptoms was and achieving competence 98%. This was published in Health Affairs in June of 2011. We measured their professional isolation in 2005. Project ECHO has diminished my professional isolation 4.3 out of 5. Enhanced professional satisfaction 4.8 out of 5. Benefit to my clinic 4.9. Expanded access to my patients 4.9 out of 5. Finally, we did a hepatitis C trial. The purpose of this trial was to train primary care clinicians and prisons to deliver hepatitis C care, to show that such care is as safe and effective as a university clinic, and that show that we can improve care for minorities. There were, in the intervention sites were 16 community-based clinics and 5 prisons. The control was the University of New Mexico liver clinic where I practice. Every consecutive patient who met the inclusion-exclusion criteria was enrolled in the trial. There was a prospective cohort study design. Participation was determined by available technology. Randomization by patient and clinician was not feasible, because if you were living in Silver City, 200 miles away, it would be very difficult to randomize you to the university arm, because you're 250 miles away. Bigger problem is if you live in Albuquerque and get your care in the university, it's even harder to randomize you to the prison. So the advantages of this design were uniform eligibility, standardized treatment, prospective measurement of endpoints, but a main limitation is that groups can be unbalanced with respect to patient covariates. The principal endpoint of the study was a sustained viral response, or a cure of the virus. Once you're cured of hepatitis C, even after we go 15 years later, there is no virus. If you have cirrhosis and you're young, it reverses, and liver cancer rates decline dramatically. These are the treatment outcomes which we published in the New England Journal of Medicine on June 9th of 2011. 68% of the patients were minorities in ECHO, 49% university, highly significant. Cure rate for genotype 1 was 50% in ECHO, 46% in the university, 70-71 for genotype 2 and 3. So we met our hypotheses that basically rural primary care clinicians deliver hep C care that is as safe and effective as a university under the aegis of ECHO, and we can improve care for minorities. But a very, very interesting new finding, unexpected, emerged. And that was that the cure rates for hepatitis C were much higher than any other community-reported trial in the United States. The VA had reported cumulative data from their 152 hospitals for treating naive hepatitis C and had genotype 1 cure rates of 20%. There were community gastroenterologists who reported hepatitis C cure rates of 34% in very large trials. So we asked ourselves, why are the outcomes so much better? We think treating patients close to their home in culturally appropriate settings by team-based care where you can bring multidisciplinary input at the same time, where patients don't have to travel long distances, where you use best practices, and where the patient has a relationship with the team that is actually providing the care, you can get better outcomes than even a specialist can do. After hepatitis C was successful, we were asked by primary care doctors to start other disease categories. So we identified 6 criteria. If the disease is common, management is complex, new treatments are coming, high societal impact, serious outcomes of untreated disease, and if you have effective treatments, you can use this model. Here there are 2 principles. The Pareto's principle is the 80-20 rule. It says that you don't need echoes for 500 diseases. There are about 20 diseases in the United States that account for most of the morbidity mortality. If you do echo projects for that, you can have a very high impact on healthcare. Second idea is healthcare is arranged in vertical domains. Everybody provides different care in private practice, universities. We want to cut horizontally using technology best practices and case-based learning to provide the same care everywhere, especially in rural areas. The key goal of Project ECHO, this is the second most important slide, is the force multiplier. It's a term I borrowed from the Department of Defense and redefined it in healthcare for a logarithmic improvement, 10 times or greater improvement in the capacity to provide care for very complex problems. How does this happen? When you use existing community clinicians like nurse practitioners, physician assistants, primary care doctors to provide the same level of care as specialists, you get force multiplication. For example, we improved the capacity for hepatitis C treatment in New Mexico more than 10-fold. And my waits in the clinic have gone down to 3 weeks from 8 months. We now have echo projects for all these different areas: cardiac risk reduction, asthma, substance abuse, chronic pain, rheumatology, HIV, and so on and so forth. We have 400 sites all over New Mexico for 19 different healthcare problems. The ultimate vision of ECHO is that in every area, let's take the bottom right, Carlsbad, we have 1 doctor with a special interest in rheumatology, 1 in HIV, 1 in asthma. So they create self-supporting networks. People don't have to travel 250 miles to come to Albuquerque to see a specialist. Why we need ECHO projects is because medical knowledge is increasing exponentially. The learning capacity of an individual physician is flat or going up slightly. Mine is going down steeply with time. There's an increasing gap between what a doctor needs to know and what he can possibly learn to provide best practice care. So what we in ECHO would like to do is transform primary care with knowledge networks so that every primary care doctor chooses an area of special interest. He's not just an expert in everything, which he can't be, but he says, I'm a generalist with a special interest in rheumatology or in hepatitis C or in geriatrics and so on and so forth. The other point I wanted to make is ECHO doesn't just train primary care doctors and nurse practitioners. We also train community health workers, medical assistants, because chronic disease management is a team sport. The potential benefits to our health system from an ECHO-like model are improved quality and safety, rapid learning, reducing variation of care, improving access for rural underserved patients, reducing disparities, workforce training and force multiplier effects by demonopolizing knowledge, improving professional satisfaction, supporting the medical home model, cost-effective care by avoiding excessive testing and travel, preventing cost of untreated disease, and integrating public health into treatment paradigm. Just to give you an example, the VA is having a national replication of ECHO right now in 11 separate regions of the United States. Just the Albuquerque VA, one of 152 VAs in the country, spent $8 million in 2009 on just transporting patients back and forth to the VA. Our current replication sites are University of Washington for those 4 diseases, University of Chicago, Harvard, Beth Israel, Deaconess, Utah, Nevada, South Florida, VA for 11 regions, Department of Defense. We have a worldwide partnership for chronic pain in the other countries shown here, also replicating Project ECHO. This is our team that has done this work. I don't want any of you to think that I had that much to do with it. I want to share some of the awards they got. In 2001, this team won the award for the most disruptive innovation in healthcare worldwide. Subsequently, they received the other grants listed on this slide. In conclusion, I have 12 seconds left. Using multi-point video conferencing, best practice protocols, co-managing patients with case-based learning, which is the ECHO model, is a robust way to safely and effectively treat common complex disease in underserved areas and to monitor outcomes. And thank you for your attention.
I'd like to thank our panelists for a wonderful, wonderful presentation. That was very inspiring. One thing that, as the 3 of you were speaking, that came to my mind is that telehealth leverages partnerships. Everything that you all were talking about, you didn't emphasize the technology, you emphasized what people could do together with the technology, and that was one of the things that came to my mind. Bill, I really liked your whole salutogenesis instead of a sick care system, a healthcare system. Joe, it was very interesting about the idea of maybe pushing the envelope on the anti-kickback issue. I'm not recommending it, but it's something that you mentioned that I thought was very interesting. And Sanjeev, that whole Project ECHO, I've heard of it before, but this is the first time that I've seen it in this kind of demonstration, and it's obviously very powerful. So I want to thank you for that. Joe, I want to turn it over to you. I know you had something else that you wanted to add to your presentation.
Yeah, I had taken so many notes this morning, I failed to mention a couple things in the presentation on reimbursement. First, kind of building on what Nina had talked about in terms of what's going on with reimbursement in general. This will sound, I hope many of you are thinking like this, and it sounds kind of sick, but my institution now is kind of looking at things going, how can we use technology to lose less money on the patients we're already losing money on? Those congestive heart failure patients that are going to be readmissions. How many readmissions does it take to do a whole lot of telehealth? And so just kind of a different concept than going, how do we get reimbursed and how do we lose less? And then a couple people asked me the question about the site of service never being defined, especially as it relates to reimbursement. How many people here remember a group called the Healthcare Finance Administration? Okay, now known as CMS. Well, back in the day when they first came out with the Balanced Budget Act in 1997, they came out with a proposed rule. And in that proposed rule, they basically said the site of the service will be defined where the provider is located. Okay, that's just what we talked about today. All the other problems tend to go away at that point. But in the final rule and their final comments, they came back and said, well, never mind. And from that point forward, the site of service has really never been defined. And so while the Healthcare Financing Administration all those years ago attempted to do that, somehow it didn't make it through. And just thought you'd like that little bit of that history. So what I'm trying to get to is I don't think the site of service is statutorily defined and can be changed.
Thank you. Okay, now I'd like to open it up for questions. Please come to the mic. And if it's not on, please turn it on before you talk. Thanks. Nina?
Thank you, everybody, for your description of your programs. Amazing information. Bill, could you? I have two questions for actually two of you. Bill, could you give us your thoughts on? You've been doing this a long time. So have we, and so have some other people. What you think the reasons are that we haven't been able to transform payment policy around some of the data that we've gotten out of population health management? And is it really about shared savings these days? And then, Dr. Arora, I was contacted by one of those programs on your list to work through reimbursement issues, and they were sort of convinced that they could get paid for what they were doing under the ECHO model. And, you know, long story short, I convinced them that no, they could not bill for what they were doing. But what are your thoughts on actually moving to a model where your consultants who are helping primary care would actually be paid under a consultation model? Thank you.
Let me just, let me make a couple of quick comments. One, if the question that you ask is about, can we take these population health kinds of things, why aren't we getting, are you really asking how we're not getting a change in reimbursements? Yeah. Well, I think a couple things. One is that, we have a reimbursement system and there are a lot of things to keep it in place, okay? So, it doesn't take to, innovation real well. So I just don't think you're going to get reimbursement for the kinds of things that we're doing with population groups and stuff. I just don't think you're going to get reimbursement because we have to move everything together, so to speak. So I think it becomes very difficult. Plus the fact that some of the results we're getting are pretty good. I just want you to know that some of the results out of very similar kinds of things that have been done aren't so good and they haven't been so great. So let me give you an example right away, and I want to be very clear about this. So a big Medicaid project in this country hires a disease management company. And they promised to pay them $20 million if they would sort out the people with chronic diseases in their group, and then save them $15 million. That was the first run. Well, after 1 year, they showed how they'd save $15 million. And I just want you to know that we were called in to do an analysis of that, and it was, of course, quite hocus pocus. This is a big, well-known company, and they hadn't done anything but pick people at the points of exacerbation, and nobody in Medicaid understood the regression to the mean that occurs with people with chronic disease. So they proved that they showed that they had $15 million in savings. I could have done that same thing with no intervention whatsoever. I mean, that is a complete what we call a placebo intervention. I could have got the same results just about because of the regression to the mean. So what happens is we haven't had as across the board compelling evidence as is probably needed to transfer the payment systems. And the second thing is, guess what? Not all this has really worked in population, especially in big groups. And a lot of disease management companies have known the secret of how you show results without having any for a long time, and they've been doing it. And so that's getting blown a little bit now, and that hasn't helped with the reimbursement.
Thank you for your question. I think that so there are two fundamental kinds of healthcare systems in the United States. So one is the Kaisers, the VA, the IHS, the military. It actually accounts for a very substantial part of healthcare in the United States. These are fully covered, accountable organizations where billing and collection is not an important part of their business at all. They adopt ECHO like a fish adopts water, basically. It's not a problem for them. Nobody has to be paid for anything. They can see the immediate travel benefits. They can see the benefits of less specialty costs, less hospitalization. A lot of benefits accrue to them. They can push any of their priorities through the knowledge networks, right? I think I know you're talking about the other part. In the other part, in the healthcare system, also there are portions such as the Medicaid, managed Medicaid programs, where these programs are paying for total cost, including transportation costs. So in New Mexico, all the managed Medicaid plans currently have agreed to pay us for ECHO, every aspect of ECHO. The primary care side to present the patients, the specialty side to provide the consultation, the infrastructure side. So that's one part. The state Medicaid also gives us direct grants for ECHO. because they see the benefit of that. Now, we would consider this one-off, but Nevada has most recently got a grant from Medicaid for the same purpose. I'm currently, just yesterday, I was in meetings in Seattle with all the health plans there, managed care, and every single one of them is agreeing to pay for it. So whenever a health plan becomes responsible for the total cost of the patient, you're going to find them as extraordinarily good partners to pay you, because it's going to help their pocketbook in a very immediate way. So I think that's where I would say is yes, in commercial plans to talk to them about, pay me $100 for a consultation, I never try that. I'm not interested in that. We are talking about partnerships to improve healthcare on a statewide basis with these health plans. That's what. So one of our health plans gave me a check of $300,000. When they first came and told me I'd give you $200 per consult, I said, I don't want it. You can keep it, right? But the thing is, it's the issue of paying for the entire infrastructure so we can create a support system for all their patients, for better access to care, less transportation costs, less hospitalization, and so on and so forth. But there is clearly a lot of interest in this. In our CMMI grant, innovation grant that we just received, every health plan in 2 states signed on as the partner to pay for it.
Next question.
Hi, my name is Dave Clifford. I work with Patients Like Me. We're a technology platform company for monitoring chronic health disease outcomes. My concern continues to be translation of knowledge into practice and the route to sustainability. And I think, Dr. Arora, you just highlighted one way of when people take on more responsibility, there's some inevitability behind doing things what I would refer to as the common sense way, coming from a field that is not medicine, coming from more of an engineering background. But then there's secondarily the struggles that, Dr. Appelgate, you're having with taking this very good 200, 300-person cohort and translating the technology packages that were paid for under the auspices of a grant or paid for underneath the auspices of a pilot study and going around and evangelizing this. You can point to a number of graphs and say, this is the right thing to do, it will save you money, you should do it. But frictionally, there's a challenge in many institutions to sort of take up those lessons of innovation. And I'm just looking to hear some of the opinions from the panel around that sustainability of what we've learned, because health systems tend to be presented with facts and quickly forget.
I'll make a quick comment about it. We do some work that have been funded by grants and some that have been funded by, I think it's fair to say, healthcare organizations and also by health plans. So we've done some for different kinds of groups, and Medicaid is an example too. One of the things I would say is that we have a thing that we do in all of our projects. So we have a lot of them that are going on that we don't run anymore because we're really a capacity building organization. But one thing I would say is we have a proof to sustainability clause that we put in our contract. So if we get money from grants with somebody, then we go to whoever the benefactor of that is, wherever this is, who we're training and building capacity to do this, and they have a deal. If we get certain kinds of results out of that deal, then they have a responsibility to continue that with their own funding, however they do that, for a period of time. And that varies, but if we do a 3-year project, then they typically have a responsibility, and it shows value over that period of time, that they would have a responsibility to run it for another 5 years or something like that, or 3 years after 1 year. And we're getting, just about everybody is signing those agreements. So a lot of these projects are going on, and they're being paid for by regular funds. So what I would say is that I feel pretty good about the sustainability feature of them, and that's one of the things that we've done with these. Is that, look, if we get these kinds of results, then when the external funding goes away, then you'll continue them. And we've had both health systems that have done that, we've had health plans that have done that, and of course we've had several Medicaid programs that have done that. So I want to say that's one thing that goes on. And some of our projects are 300, and some of them are 700, and sometimes they're limited just by the fact of the amount of money that we have from external resources to do it. We did one with a Medicaid program that was with 400 people. Now that program is being run, same program under Approved to Sustainability with about 1,600 people. So,
just like to echo what you said, we have very little grant funding at Lehigh Valley Health Network. We do have a trust which funds some programs, but the telehealth function has been placed under the Chief Strategy Officer. So going forward, it is part of the strategic plan of the network.
I think thank you for your comment. From our perspective, the issue we are trying to solve is exactly what you're talking about. There are 17 years to take best practice to the last mile of healthcare, as you've heard that, and less than 50% of people are getting best practice care. So the question is, it's easy to say the primary care doctor is not really doing as good a job as he could. The point is he can't, because if I came to you today and said run a 100-meter dash in 9.59 seconds, which we just saw, it's not hard. It's going to be hard for you to do it. And the same is true with this knowledge explosion. The primary care doctor cannot do it. It's impossible. So now the question comes is, the way we try and solve the problem is just one way, as you said, maybe many others are there, where we have them narrow the scope of their practice and give them the mentorship they need to provide the best practice in a particular area of their choice. What we've found as far as payment is concerned, that I am not approaching health plans for funding at this point. They are coming to me to fund us. So I would submit that the one possible reason that telehealth is having some difficulty is that we haven't shown adequate value. I think the important here is the healthcare leadership plan are extraordinarily sensitive to value. They can smell it out from anywhere. They're in business to make money and to provide better care. And so if we were to provide compelling evidence for value, I think these reimbursement problems will solve themselves automatically. I think the challenge for us is the evidence for value has not been compelling enough from their perspective. It has been compelling enough from our perspective, but we are sort of preaching to the choir, but it's not been compelling from their perspective, and we need to do whatever it needs to do that, make that happen.
Okay, we're going to take 2 more questions. We have 3 minutes, so go ahead, Stuart.
Okay, I'll go in 90 seconds and then let Dale go. 2 of the speakers gave examples of telehealth programs that did not achieve the same results you achieved because their protocols and designs were different, specifically Joe and Bill. And I think that's really something that's very key to this. If we start to go mainstream and this grows, there's a way to do telehealth that achieves results, and there's a way to do a telehealth that doesn't achieve results. So I just pose it to you with 30 seconds left. Where do you see the role of best practices and practice guidelines in telehealth, and what would the role of that be in growing this field into a larger scale?
It's key. I think that that's part of the reason that the value proposition to the payers is not clear, because they see these contradicting articles and they say, I don't know what to do. I think that we have to define a value proposition in the times of trials, plus the exact methodologies of how to do it correctly. Otherwise there's going to be a constant challenge for us. Yeah.
I don't know any other way of doing it than writing a book and why some programs work and why some don't. Because it's all over the country. You can see various programs that have had great results, and then you see those articles that come out, and sometimes, unfortunately, the payers like to hang everything on the ones that don't work, and as a way of saying, I'm not sure I want to pay for this, while other programs have great results. Stu, I don't know how we roll that out, but we need to.
Sure. One of my comments and my loving recommendations to HRSA was that I think some of our projects that are funded by different agencies need some good technical assistance sometimes, and I don't know exactly how to make that work, but I think that there are errors that are evident in even really good proposals, and so I guess there needs to be somewhere along the line there needs to be some good crap detection, I guess, or technical assistance. I don't know what the real word is, but so.
Stu, just one more thing on that. There's this group called OAT that funds these regional telehealth resource centers. Perhaps they could assemble that information on programs that really work and those that don't.
Yeah.
Because they're the ones in their regions that have access to this information.
And there's a lot of different kinds of programs. I mean, because we're involved in telehome care programs, and you funded a lot of telehome care programs, and I don't think ours looks like anybody else's. Okay, I mean, it just doesn't. And I'm happy with that, but it's not the same as everybody else's. So.
Okay, Dale.
I'll try to. Dale Alverson from the University of New Mexico, and these are great presentations, and of course, what great respect I have for Dr. Arora and what he's done with Project ECHO. But with the question of the panel, one of the speakers and writers about this whole issue of healthcare reform and cost is Atul Gawande. And a lot of you sort of touched on parts of that, and I'd like to get your comments about that. I mean, he's talked about the cost conundrum and looked at McAllen, Texas, and compared to El Paso, but no better outcomes, and then talked about the hot spotters. He's really gives some really compelling arguments about changes that have to occur in the system, and you've all touched on that about unnecessary variations in care and following evidence-based best practices. And I wonder if you could perhaps close with commenting on what Atul Gawande has been commenting on for some time.
Well, I think one of our CMMI, I'll start with the second part first, the hotspotters. Our Center of CMMI Innovation Grant is strictly focused on developing outpatient intensive care teams to basically develop a new specialty in medicine for the care of the 5% of Medicaid patients that consume 57% of the resources, supported by ECHO-like knowledge networks. So we are right on that trail right now, the hotspotters. The second part about reducing variation, that really wasn't ever the goal of ECHO. But what we find is the second pillar on which ECHO stands, first being technology, second is best practices, is that when we disseminate best practices, variation automatically reduces. So let me give you an example. If I'm a gastroenterology doctor, and I like to do colonoscopy on patients frequently, when I'm on the knowledge network, I have to follow best practice. We are a community of practice in which best practices are being discussed automatically reduces variation just by peer contact. Just like we all behave better when we are a part of our peers, the same way professionals gravitate towards a mean. There's much less variation when you have to discuss your decisions in a peer forum. And it's an automatic system property of the ECHO model to reduce variation.
Dale, my bad. I guess I missed the article. But in terms of variation, I think a lot, since I've been in two different institutions with telehealth programs, a lot of it comes down to politics. Who should, in the ICU environment, sometimes they're open environments where multiple different providers cover those units. And sometimes they don't want others consulting on their cases. And so it's a culture. And in our case, we decided to close the ICUs long ago, before the advanced ICU was even created, so that the intensivists managed the care in those units, and if need be, brought in a specialist who may have put them in there to begin with.
I'm really a student of Gwendy's cost conundrum article. I love it. There's all kinds of things in it. I would say one thing about that article, and he has lots of other really great ones, as you know, too. I'm a student of them mostly. I love to watch them and read them and think about them. But I do think in terms of what we deliver in what we do with our population health management and also with our telehome care kinds of things, I just say we have to make it work wherever the costs are. And it does show value just about any place. So even though there are great regional variations, as he talked about, and illuminated, by the way, when he talked about the two that he talked about, but I just say we still have to make our things work wherever they are. I don't think the margins are good enough to say, well, you know, CMS has always said, as we've done some projects with them, we've always said, you know, will it work in Miami? Okay, I mean, that's kind of the favorite question. So it works here, will it work in Miami? And I just want you to know, I know I've heard that 30 times. And I guess what I want to say is that's a fine question. And the reason it's a fine question is whatever it is we're doing, it should be the kind of project that'll work in Miami, and it'll work in Norfolk, and it'll work in a lot of other places. So I think we need to develop strategies that really bridge that cost conundrum issue. So.
Okay, please join me in thanking the panel.